Hello, everyone. Thank you for coming to our webinar today. My name is Tammy Mulm. I'm the Director of Education at PQA, and I will be your host. Our topic today is AI-driven medication use quality as a vehicle for value-based care, insights from a multi-state health plan. Before we get started, I'd like to walk you through a few housekeeping items. First, please submit your questions throughout the presentation using the Q&A feature at the bottom of your screen. We will include your questions at the discussion at the end of the webinar. Also, the webinar recording and slide deck will be available to PQA members within a week following the presentation in the Member Resources Library section of our website. You'll also be able to access the recording of this webinar on our YouTube channel. Lastly, I'd like to encourage all attendees to complete the quick 1-minute survey that will appear at the bottom at the conclusion of our webinar. The growing use of artificial intelligence by PQA members and stakeholders to identify, engage, and support patients in their medication use has made AI an important area of interest for PQA. This webinar is an encore presentation of a highly attended session at our annual meeting in May. Today, we are excited to continue the dialogue around AI in this important space. It is my pleasure to introduce to you today's presenters. First, we have Amy Chuang, who is the Director of Clinical Pharmacy Programs at Cambia Health Solutions. Also with us is Yoona Kim, CEO and co-founder at Arine. Thank you all for being with us today, and with that, I will turn this over to Amy.
All right, welcome everyone. Before I dive in, let me give you a little context about who we are at Cambia Health Solutions. We are a nonprofit healthcare and technology company with 7 regional health plans. The focus of our conversation today is on the 75,000 Medicare lives we serve. About 3 years ago at the PQA Annual Meeting in 2023, I met Yoona and learned about Arine for the first time. I had no idea that conversation would lead to what I'm about to share with you today. So let me take you back to where we started and why we knew something had to change. Okay, so we were managing 3 critical programs, medication adherence, MTM CMRs, and quality gaps, but each one operated in its own world. Our PBM managed adherence independently with a separate member list and outreach process. MTM was handled by a third-party vendor used mainly for that single purpose. And our quality care gaps were worked on by our own internal team using very fancy Excel spreadsheets and with no connection to the other outreach efforts. Honestly, we had dedicated teams working hard. Each of these teams were very engaged, but no one was talking to each other. This means members can get multiple calls in a week, and it was difficult to coordinate efforts. So despite all that effort across 3 programs, we kept seeing inconsistent quality performance. Without a shared platform, clinicians were working from separate tools with no visibility into each other's work. And that's a frustrating place to be. You're investing resources, your teams are engaged, but the results aren't reflecting the work. And that inconsistency forced us to ask harder questions. We realized that we couldn't answer 3 fundamental questions. How do you coordinate outreach across vendors working on different measures? How do you prioritize which members need intervention most? And how do you know which interventions are actually driving quality performance and cost savings? These weren't small gaps. They were blind spots that no amount of additional effort could fix within our existing model. So when we looked honestly at our medication quality work, medication adherence stood out. It carried the greatest combined impact on both quality and cost. Three quick facts that reframed how we thought about this, and you all probably already know this about medication adherence. They are triple weighted star measures. And together, all three of the adherence measures represent a meaningful portion of the overall star rating. And better medication use means fewer hospitalizations and fewer ER visits. This led us to our central question, which is how can we optimize quality while also reducing the cost of care? So when we set out to solve these problems, we weren't shopping for AI. Honestly, we didn't even know AI was what we were missing. We thought our challenge was a vendor coordination problem. If we could just get everyone working on the same list, on the same platform, things would improve. What we didn't realize was the deeper issue was intelligence. We didn't have a way to predict which members to prioritize, which interventions would work, or how to measure impact in real time. A single platform was part of the answer, but a single platform powered by AI was the full answer. So I'll hand it over now because I can tell you what the results look like from our side, but the team at Arine can show you how the technology actually makes it possible. Yoona, it's all yours.
Thank you, Amy. All right, so before I dive into the solution itself and how do we do what we do, incorporate AI with a single platform to help our clients achieve the highest quality ratings as well as cost savings, I will introduce Arine. So Arine is a medication AI company. Our mission is to ensure safe and effective medication therapy. I myself am a pharmacist and health economist by background, so I really am passionate about these medication interventions, both improving quality while reducing healthcare costs and unnecessary complications caused by patients being on the wrong medications. At Arine, we're serving over 45 different health plan risk-bearing provider clients. We're actively managing more than 45 million members, and to date, because of the outcomes we're able to achieve, we maintain 100% client retention rate. Next. Right. So before I dive in, let me first define medication AI. So this is how we define it at Arine. It's a clinical intelligence platform that uses AI to identify, predict, and intervene on medication-related risks, reducing problems, improving outcomes, and lowering the total cost of care. So if you notice, that emphasis really is on what outcomes AI can deliver rather than the AI itself. But I will explain a bit about how we do what we do. So in a nutshell, this slide shows the data flow within our platform. So we take the medical and pharmacy and eligibility claims at a minimum. We also pull in other claims that are available, SDOH data, plan formulary, provider type of data. And then from there, that data flows in our platform on a continuous basis and flows into our models that target the right patients to intervene on, and then a second set of models that targets the right interventions. And then from there, our platform will generate patient-facing educational materials and care plans, as well as if there's a needed prescribing change, a prescriber-facing recommendation that can be sent to the prescribers directly from our platform, either through EHR connection or secure fax or other modes of communication. And then on an ongoing basis, the core of our platform is, again, the emphasis on the outcomes and analyzing those outcomes on a continuous basis. So if it's the medication adherence outcomes, we are looking at the adherence rates on a daily basis, and then using that data. So we're not seeing the needed improvements. There's a feedback loop that goes into hone both our models to target as well as our intervention models to always get to the desired quality and cost goals. So if we break this down into what are the components that lead to achieving those outcomes, and the first foundational layer is really, it starts with the data. So comprehensive data sets are incredibly important. That allows us to look at, again, the medical history, the medication history, the social demographic characteristics in order to, again, learn off of the full member comprehensive picture. So in Cambia's case, we brought in the eligibility data, pharmacy claims data, medical claims data, but also call time preference data, provider information, and formulary data. So that's the data that we pulled into our platform. The second element that's important to note is that as that data flows in, of course, it's not static. So as that data flows in, we are actually updating actively our models on targeting as well as our intervention models. So at that time, we are surfacing the members who need that intervention at the right time. So for example, if a member is tagged as needing an adherence intervention, and then the next morning a claim comes in that the member actually has a paid claim and picked up their medications, then the task gets automatically deleted from our task queue. So clinicians are only reaching out to members if and when they need it. And this also helps with better patient satisfaction as well. The other important piece of this medication AI platform is the continuous learning. So I described a little bit about that feedback loop. So we really go beyond just flagging the members, but we're actually tracking the interventions and what interventions work. What are the types of interventions the member will respond to? What are the channels of communication the member will respond to? And we are using that data to continuously improve our outreach and achieve outcomes at scale. I wanted to give a couple examples of our models that target the right patients to target. So this is an example of our adherence modeling. So Cambia is using these models, and what they do is, again, they use machine learning technologies, and they pull in hundreds of different data parameters, and we predict the likelihood of being adherent at the end of the year, as well as year-end adherence rates. And then also in measure status. Of course, this is very important because you want to be able to outreach proactively before the member enters a measure with their second fill and get them on track at the very beginning. So what this type of predictive modeling then allows the clinicians to do is, again, target members if and when they need the outreach. We couple this modeling with other metrics like next refill due date and days to goal not reachable in order to, again, really pinpoint the timely intervention. Cambia is using our multiple solutions in Arine's platform. One of them is, of course, targeting the quality measures. The second solution that Cambia is using is also our Luminate solution and this solution is targeted at identifying high-risk members in order to reduce total cost of care. So this is an example of our models to identify those who are high risk. So again, we use machine learning technologies here so we can take into account hundreds of data parameters. And then we pull that data through an ensemble of 4 different ML models. One looks at predictive inpatient risk. So this predicts the likelihood of having an admission in the next 6 months. The second model looks at predictive cost risk. The third model identifies medication risk, untreated conditions, potential drug interactions, adherence issues, etc. And then the last model is our own impactability model. So across our 9-year history, which types of members have we seen a cost of care impact? So the outputs of these 4 models generate a prioritized list of high-risk members. And like our other models, they are dynamic. So as new data comes in, we are changing the risk score of these members and reprioritizing them for outreach. So the clinicians are always reaching out to the members who need it most at time. I spoke a little bit about this dynamic prioritization. So a lot of things changed the risk score, new diagnoses, any hospitalizations or upcoming risk of hospitalizations. missed fills. These are the data elements that will change that risk score. The risk score is then visible to the clinicians in our task queue, and they are able to see also the reason why that risk score has changed. One other important piece of the intervention side is actually going beyond check the box. So at the time the clinicians are doing an outreach for medication adherence, for example, because we are processing the full member profile, we can actually see if there's other inappropriate medication use that's happening within that member. So we are identifying not just the adherence issues, but also improper dosages, unnecessary duplications, dangerous interactions, ways to optimize their chronic condition medications. And this is, again, how we both improve quality while reducing cost of care and preventing things like costly hospitalizations and emergency department visits. So I spoke a little bit about our machine learning side that runs our predictive models. We also have a lot of new Gen AI capabilities, and these capabilities are there to enable the clinicians to work at the top of their license. So we have these capabilities, and before the call, for example, the Gen AI will generate a personalized call script. Surface the information and summarize the key information in advance before the call for the clinician, so the clinician knows what to pinpoint during the call. And then during the call, we have ambient listening technology, and I'll demo this as well, that will automatically populate the notes, capture all the clinical details, and flag relevant information for the clinician that comes up during that call. And then after the call, the platform will summarize the call notes, will automatically log the interactions that have taken place, and then save that information so that each call builds from the last and learns from the last call in order to generate the right next action from there. So with that, I will demo the ambient listening call and restart it so you all can hear it.
Hello. Hi, my name's Eunice. I'm one of the clinical pharmacists here. Am I speaking with? Started me on a different medication for my blood pressure, but they make me feel so dizzy that I don't take them every day. Got it. And I'm reviewing your medication list now, and I can see that you filled 2 medications, specifically the lisinopril and the valsartan. These medications work very similarly in your body, and taking them together may increase your chances of experiencing side effects of these medications. Are you taking both of these medications? I am. Got it. And have you seen your primary care physician since you left the hospital? No, I did make an appointment with him, but it's coming up later this month. Okay, great. It's really important that you see your doctor after a hospitalization to ensure that they're up to date on any changes to your health. And in this case, it may be a good idea to clarify with the doctor if you should be taking both of these blood pressure medications together. Could I just confirm that your primary care physician is Dr. Garvigian? Yes, that is my doctor. Okay, great. I will give him a quick call to inform him about the medications, and either his office or I will call back regarding the next best step forward. Regardless of the outcome, I do want to emphasize that taking your blood pressure medication is very important to do every single day. Hypertension is a chronic disease, and the best thing that you can do to prevent this from damaging your body over time is to keep your blood pressure in normal range by taking your blood pressure medications every day. If you feel side effects from your medications or have questions, talk to your pharmacist or your doctor right away instead of skipping them on your own. I understand. And I just want to make sure you're not having any issues getting your blood pressure medications. Can I ask if you would benefit from getting a larger supply of your medications? Is that an option?
Yeah, I noticed you're getting 30-day supplies of your medications. This means that you're going to the pharmacy every month. If you switch to a 90-day supply, you'd only have to make 4 trips to the pharmacy each year.
Oh, yeah, that sounds amazing. Can you help me with that?
Yeah. When I clarify the blood pressure medication with your doctor, I'll ask the doctor's office for a 90-day supply. Were you also interested in getting your medications mailed to you?
No. I think I like going to the store to do my shopping.
Got it. I completely understand. Walking is a good form of exercise. And is there any other questions or concerns that I can help you with today?
No, just let me know whether I should continue to take all these medicines.
Got it. As soon as we hang up, I'll call Dr. Garabésia and I'll get things clarified.
Okay, great.
All right. We'll talk to you soon. Thank you so much for your time.
Take care. Bye-bye.
Bye.
So as you can see from the screen, and apologize for the technical difficulties with Zoom audio, but as you can see, the system was walking the clinicians through, flagged the duplicate therapy at the start, had the clinician remember to confirm certain information. Then the system automatically logged the different interventions and also recommended the next steps that, again, the clinician can confirm and execute on. So there is a clinician in the loop where the clinician can review every input before confirming it. But this system does make it very efficient for the clinician. So we have our own in-house clinicians using this today, and the feedback has been that it does definitely allow them then to spend time on the patient counseling rather than the administrative tasks of taking notes. In addition to that, what ambient listening allows us to do is get all that rich data, things that the member is saying about what they do on a daily basis with their medications, side effects that they're experiencing, how they take their medications. And that then can be fed into our models as well for both, again, the member targeting as well as the intervention models. The other AI capability that we have up and running are AI agents. Again, the purpose of AI agents is to free up clinician time. And so what these agents are doing is doing administrative tasks. So for example, we have AI agents up and running, calling pharmacies to both automate the refill process, help members execute on their refill request, also check on prescription status. Again, that allows then the next best action to be more seamless. For example, if an AI agent is calling a pharmacy and discovers that member is out of refills, then the system will automatically log that and set the next action as getting in touch with the provider to write a new prescription. We also have AI agents calling providers and members as well. But the result is more time for the pharmacist to focus on high impact interactions without compromising on execution. So I'm going to also show you an example of one of our agents calling a pharmacy to check on prescription status. Hopefully the audio will work this time.
Hello.
Hello. This is an automated AI assistant calling from Arine regarding a prescription status. This call may be recorded for quality and training purposes. To continue, may I speak with a member of the pharmacy staff?
This is the pharmacy staff speaking.
Thank you. I'm calling to find out the current status of a prescription for a patient. Could you please check the status for prescription number 387652?
Yes. Can you give me that prescription number again?
Of course. The prescription number is 387652.
Okay. And the patient's name?
The patient's name is James Chen.
Okay. And what's their date of birth?
The date of birth is March 22nd, 1965.
Okay. And what's the actual medication name that you were wanting me to check just to make sure it pulls up the correct one?
The medication name is Lisinopril.
Okay. Yes, I have that pulled up here. The Lisinopril was last picked up in March, on March 1st for a 30-day supply.
Thank you for that information. I appreciate your help. I'll go ahead and end the call now.
So again, that was an example of our AI agent call, and you know, we're having a lot of success with those calls. As you know, like clinicians also often interact with IVR systems at pharmacies, which take a lot of time away from clinicians being able to counsel members. So we have also our AI agent interacting with the IVR system, gathering that important information or helping to facilitate refills, and that shaved off about 10% of time the clinicians are spending just checking on prescription status and refills. So it's been very productive for folks using our platform. This slide really touches on safe and responsible AI use. So AI is interesting. There's a lot of talk around it. The rules and regs are changing around it, and we have to be at the top of our game to make sure that we're monitoring for any changes in regulations at the state and federal levels, but also doing our part as a healthcare company to ensure safe and responsible use. So we do have our own AI governance committee in-house. We have external experts who sit on that committee, including a physician who's built these AI systems at large payers, and a health policy expert, as well as our internal head of AI and our data security folks as well, who sit on this committee. And one thing this committee has done is, again, put out these policies and procedures of how we will handle everything from bias and fairness testing to what type of validation is required before we put these models out in production and before any feature goes out into production. And in addition to that, importantly, there is always a human in the loop with our AI feature and functionality today. So clinicians are able to review and confirm every recommendation, every AI output before they are distributed to the members and their care teams. And then one thing that Cambia's AI governance committee that was very important to them was this data privacy and zero retention, meaning all data stays within HIPAA compliant environments. And we're using Cambia's data for specifically fulfilling the scope of work and the agreements that we have with Cambia. In addition to that, we are meeting with, again, our clients' AI governance committees as well on a regular basis to share with them our validation protocols and our bias and fairness testing protocols and outputs. Okay. So this summarizes our technology really in a nutshell, where we have models that run the member selection, identify then the right members to target for that program. And then we have models that identify the interventions that the members need. And within our platform, we think it's very important, again, to really robustly measure the outcomes. So we're comparing outcomes against similar members, matched controls, in order for us to understand what's the incremental impact of Arine's interventions. Then we're using that impact data to continuously improve both our patient selection models as well as our intervention models. Okay. So in this next section, I'm going to try to bring to life how the care teams are using medication AI and our platform. So first, I mentioned those patient selection models. Those outputs get surfaced in our task queue that prioritizes members for outreach. So when clinicians log in, they can see clearly what tasks are high priority, what is that task regarding, who is it assigned to, and the due date of that task. And in Cambia's case, there's multiple programs. So across multiple programs, we are prioritizing the right outreach. So for example, the task that surfaced to the top in this case is a member with high hospitalization risk. So that task has surfaced as the most urgent task to address. So the pharmacist from there can then easily click in to the member profile. In that member profile, the pharmacist will see what is the reason for hospitalization. This case, the hospitalization was due to heart disease. They can see the member demographics. They can see the past medical history of AFib, diabetes, hypertension, atherosclerotic disease, depression, and they can see also the list of medications that that member is taking and even the adherence rates of each of these medications. So you can see the different medications listed here at the bottom of the slide. The other thing that the clinician can see is that this member got a recent A1C test done. The A1C was high at over 8, and then also blood pressure is trending high as well at over 130/80. So again, the clinician can see everything in one view. And then the platform will also generate the actual recommendations for the clinicians to review. So the gaps in therapy identified by the Arine platform includes adding an SGLT2 due to their high A1C and that diabetes measure, adding an ACE inhibitor due to both hypertension and diabetes and the recent high blood pressure readings. Because this member also has a history of fall, the platform also recommended treatment of alendronate as well. And then the platform recognized that it was time for this member to also have cognition and memory screening according to the ADA guidelines due to fall risk and age. So the clinician then can see these recommendations. One other thing I will note is that we always align the recommendation with the plan's formulary. So our platform will, for example, recommend the SGLT2 that is covered by the plan's formulary and something that is the lowest out-of-pocket cost for the member. The pharmacist, while seeing these recommendations, can provide simultaneous counseling to the member and then directly from our platform, fax these recommendations over to the provider to make the needed prescription changes, like adding the SGLT2 and the alendronate to reduce vascular risk. For this particular member, by getting them back on track and reducing their fall risk and back on track with their A1C and blood pressure, this member had no further hospitalizations, even though they were recently hospitalized prior to interventions. And then we are continuously monitoring this member. Again, the whole entire medical claims is flowing into our platform, medication claims also flowing into our platform, so we can see if there's any changes to this member's ongoing risk. So again, through what Amy was mentioning was it doesn't just take a single platform that will coordinate these measures, but also that will prioritize the interventions that are needed across these measures. And also the AI is there to help with the actual outcomes achievement as well. We don't like to compromise and look at stars only. We like to go beyond check the box. So it's not just about stars, it's also about the cost of care impact that we can have with these very important interventions. And with that, I'll turn it back over to Amy to talk about the specific implementation and results.
Thank you, Yoona. All right, let me advance here. All right, so I wanted to share some keys to a successful implementation. 3 things made our implementation with Arine successful. 1, data integration. So as Yoona mentioned, we needed to connect medical claims, pharmacy claims, eligibility, labs, provider information, all into one view. Next is workflow integration, having one shared task queue across teams and replacing the silo lists we started with. And lastly is care team alignment, making sure that there is standard documentation and consistent platform use so everyone operates from the same playbook. So these 3 things were key to having a successful implementation, but I want to add something that isn't on this slide because it made a real difference for us, and that was having a strong project manager. for the implementation. Implementations like this involve multiple teams, multiple data feeds, and a lot of moving parts. And things can slip without someone keeping everyone accountable. Arine provided an exceptional PM who kept all teams aligned, on top of deliverables and on schedule. So that partnership was a key reason we were able to launch smoothly and start seeing results in year one. So if you're evaluating vendors, I'd encourage you to ask not just about the technology, but also about the implementation support. It matters more than you might expect. All right, so in 2024, 2024 was our first full year with Arine. I'm sorry, 2025. On the slide, you see our results in year one. And so we saw a 2% increase in medication adherence for our largest age contract and 1 to 5% improvement across all contracts. That may sound modest if you're not familiar with the adherence world, but if you are familiar with adherence star measures, you would know that this is a huge increase, especially since, in the past, when we tried other ways, we may see either no change in medication adherence or an increase by 0.1%. This improvement was seen across all three adherence measures, so diabetes, hypertension, and cholesterol, and it reflects a systematic improvement in how we identify and engage members. We also implemented cost of care work with medication AI, targeting high-risk, high-cost members, as Yoona mentioned, and this program resulted in a $3,500 per engaged member per year savings. Let's see, next one. All right. So the idea I want to leave you with is that this is not a quality or cost conversation. It's both. It's about how to optimize both with the same strategy. One, strategic change, the right platform, the right data, the right prioritization can move STAR's performance and cost of care simultaneously. So AI helps you find the right members and measure, and will tell you what's actually working. So if you're still running separate programs with separate lists and separate platforms, I'd encourage you to ask yourself the same 3 questions we couldn't answer and consider whether it's time for a different approach. And I believe that is it. Thank you, everybody.
Great, Amy and Yoona, thank you so much for sharing this important collaboration between Cambia and Arine. Again, if you have any questions, please put them into the QA feature located at the bottom of your screen. We will answer as many questions as we have time for. So, Amy and Yoona, how do you provide and receive vitals data like blood pressure for patient example Cindy or CCDs, EPPs? Have you started using ADT feeds also?
Yes, so directly from Cambia, we are getting some lab data from Cambia. So we do partner with our plans to get that data. Some of the plans are getting it through their provider relationships. In addition to that, we have been using ADT file feeds and pulling in CCDA data files. So we do have partnerships with HIE type of companies like Zeus Health, Particle Health to pull in that data if and when needed to supplement the data that we get in the claims.
Great. And for the data integration, can you address further how unstructured patient data is used, such as patient feedback, sentiment, or SDOH information?
Yeah, so we're pulling in a lot of this data again from those conversations. And we also have something called smart questions within our platform. These prompt the clinician to ask certain questions. So we notice the member lives in a low income area and has non-adherence patterns. Then we may ask some questions around their SDOH, such as access to transportation. And then before we get started with the plan, we do ask them, what are the resources that you're offering to your members? What is your formulary, so we can offer the lowest cost option, your 90, 100-day copay structures, also things like their transportation program. And upon finding out these SDOH barriers, we do, again, automatically then generate the recommendation from there. So in the case of a transportation barrier, we will have a recommendation that surfaces around that plan's transportation program, so the member can actually get to the provider's office so that they can get their prescriptions, or they can get their prescriptions delivered through the mail order program.
Wow.
And it also helps us to really target patients and understand things like reasons for non-adherence or reasons for their high risk. So the sentiment elements, they're extremely important as well.
Yeah, absolutely. Our work is adjacent to the SDOH barriers as well, and it's really cool to hear all that work that you're doing. Does the prescription fill history include cash pay prescriptions?
So the prescription fill history typically does not include the cash pay, but we can ask the pharmacy if there are any of the information, and sometimes we can get that from SureScripts as well. So there are other, and then directly from the members themselves, and all that information is also recorded in our platform too, and incorporated into our recommendations. So say, for example, the member says they are, they're paying for a GLP-1 cash pay. We can enter that into our platform and run press a button that says rerun analysis and run our recommendations in real time, so we can incorporate that latest information.
Great. Is there any data on the rate of calls accepted or dropped by patients that involve AI versus those that do not involve AI?
Yeah, so we do have some, right now we have thousands of calls that are happening between an AI agent and pharmacies. The success rate from start to finish is about 55%, meaning like when an AI agent calls a pharmacy to say facilitate a refill, 55% of that time, that refill is successfully completed from start to finish. We do have some member calls in proof of concept right now, but we do not yet have the success rate. I will say though that as we are making these calls, like even with a pharmacy, say we identify that a particular pharmacy, the success rate is very low and they don't tend to respond to an agent, we turn off the agent to make those pharmacy calls because we don't want to cause any abrasion. So that is something that we are monitoring. In fact, we have like daily monitoring that's happening and live dashboards that are happening about the accuracy, the latency on these calls, the success rate, and so that we can again continue to train our agents, as well as when needed, stop calls because it will cause abrasion.
Yeah, that is fantastic. And speaking of accuracy and abrasion, how do you track the accuracy and how do you make that decision as to when it's no longer being accurate?
Yeah, so every call is monitored and through our system, so we can see what call has gone out to, who has it gone out to, what's the pickup rate, was the agent able to complete the task on hand and successfully log that action within our platform. So everything again is monitored in live dashboards, and if we see any like suddenly that success rate goes down, that kicks off a review process.
Great. You had mentioned also that you optimize patient experience and satisfaction. Can you share how you achieve high provider experience and satisfaction?
Yeah, the thing from a provider perspective, what's really important is that we build trust with providers with our recommendations. So when we send the recommendations to providers, we take a very data-driven approach. Automatically within the recommendation, the data context is incorporated as well as reference to the treatment guidelines and why we are surfacing this recommendation. For example, if the recommendation was around escalating inhaler therapy, the recommendation will include information like the guidelines, what's maybe the members expressing in terms of their shortness of breath symptoms, and then we'll recommend a inhaler therapy that's covered by the plan's formulary. So from a net promoter score, and this is consistent with Cambia's data as well, there are, again, we have a track record of both 90 plus for both member and provider NPS.
Wow. Amy, you are balancing quality outcomes, member experience, and resource constraints. Were there any findings that changed your assumptions about which members would benefit most from one of Arine's interventions?
Yeah, I mean, switching to Arine and having everything in one platform allowed us to see which members had multiple care gaps. You know, maybe we're also trying to reach them for MTM, and then also they're a high risk, high cost member. So it's great to be able to make one call and address everything on one call. And those are the members that should be prioritized because they have so much going on and they need help. They need somebody, a clinician who cares and, you know, is able to help them through that journey. And sometimes it's not a one call takes care of everything. Sometimes there are follow-up calls. And so it was much easier to see those kind of patients in Arine's platform, you know, so we can prioritize the people who need help the most.
That's great. One platform plus what Yoona's saying of constantly tracking that data, making sure that it's true, making sure that it's accurate, making sure that we are providing that satisfaction, decreasing that abrasion where possible, has allowed you to therefore tackle those patients that need the most amount of help.
Exactly.
That's fantastic.
And I will say, like Cambia, likewise, Cambia has been a great partner as well with that vision of trying to, again, go beyond just the care gaps, also cost of care, and looking at the holistic population view and holistic population health. So they've been, it takes that aligned vision as well that makes the program successful.
I love that. We talk about aligned visions a lot too. One more question here. Do your AI models tailor interventions for diverse or non-English speaking patients?
Yeah, they do. We actually found that Gen AI is quite good at translation, better than other translation tools that are out there. So we use Gen AI to help, again, translate into other languages. To date, we have Chinese, Vietnamese, Korean, Spanish in our platform. And again, with these new models that are out there, it's faster and more accurate to translate information into language preferences for members.
Okay. I will cut our Q&A off there. Thank you everyone for submitting your questions. It was an active chat box today. We're going to bring up our slides here and I'll finish with a few announcements from PQA. All right, first, please save the date for our upcoming industry spotlight with Clarist Health on September 17th at 1 p.m. This webinar is open to the public and will examine how health plans and clinical teams can bridge the gap between pharmacy operations and medical economics. Registration will be open soon, so please keep an eye on your emails. Additionally, our quarterly member webinar will be held on Wednesday, October 28th at 1 p.m. As indicated, this one is open to members only. Next, our Leadership Summit and Pre-Summit Workshop are right around the corner. The pre-meeting workshop, using the PQA Medication Therapy Problem Categories Framework in Practice, We'll explore approaches for supporting consistent application of the framework across pharmacists, organizations, and practice settings. This program will be offered as an ACPE accredited continuing education activity for pharmacists. It will be on November 5th from 9 to 1:30 in Arlington, Virginia. If you are interested, we will put that registration link into the chat. Immediately following the workshop will be the 2026 PQA Leadership Summit, where we will explore PQA's growing work to recognize pharmacies committed to continuous quality improvement, patient-centered care, and value-based performance through development of a national recognition program. Leadership Summit will take place on November 5th, 6th, also in Arlington, Virginia. We have sent registration information to the key contact for each PQA member organization. So if you have any questions about either the workshop or the Leadership Summit, please email meetings@PQA, which we will also put that contact info into the chat. Last, the call for breakout sessions and poster abstract proposals for the 2027 PQA Annual Meeting will open at the end of August. That meeting will take place May 10 through 12 in Indianapolis. Once open, the portal will remain open until November for sessions and January for poster abstracts. Please check back on our website at the end of August for more details and a link to the submission portal. In the meantime, should you have any questions, email us at education@pqa.org and we'll put that email into the chat. Thank you all for joining today's Quality Forum and have a great day.